Hello everyone, my name is Amir Ali. I'm the current PGY2 resident at the Norris Comprehensive Cancer Center at USC. And today we're going to be discussing both prostate cancer and breast cancer. Starting off with the breast cancer lecture, I'd recommend you listen to this lecture first as it contains information that might be helpful for you while you go through the prostate cancer lecture. I'm sure breast cancer and prostate cancer can be a sensitive topic for some of you who have family members dealing with these types of cancers. And if you're planning on going into oncology in the future, these are topics you'll certainly need to know in order to practice as an oncology pharmacist. And for those of you who are not that interested in going into oncology, these are important and fairly basic key points that you would need to know about both of these cancers as a pharmacist in the field, whichever field you're planning on going into. In terms of required readings for these two modules, I'm thinking the NCCN breast cancer and prostate cancer guidelines would be pretty key for you to review. This is kind of the guideline of choice for many oncology pharmacists, and we often refer to them when we are consulted or verifying chemotherapy regimens. You can go to the NCCN website to make a free account and access the guidelines from there. So these two lectures, both the breast cancer and prostate cancer lectures, are going to be fairly different than previous years. I've tried to take some constructive feedback from your previous classmates and simplify the lectures, keep it to the key points, and I hope the adjustments I've made for this lecture will certainly do so. And feel free to give me feedback afterwards. Last point is, before we get started, office hours. So as you may know, these two modules will not have a synchronous lecture associated with them due to your reading day that was assigned on the same day. So instead, I'll be hosting office hours, and I'll send you all an email letting you know when the office hour will be. I'll definitely highly recommend you attend the office hour, though it will not be mandatory. Okay. So, starting off with the objectives, which you can see on this slide. I'm not going to go through each one of them, but by the end of the presentation, they'll all be addressed. We'll begin with the epidemiology of breast cancer. So all the data you'll see in the next couple slides is either pulled from the CDC or the NIH. You can see that breast cancer is one of the most frequently diagnosed cancers globally, and is the leading cause of cancer-related death in women. You can see 250,000 people are diagnosed with breast cancer each year, and roughly 20 to 30% of them are HER2 positive. We'll discuss what HER2 means. And 7% of patients will have metastatic disease at diagnosis. So essentially what that means, if you haven't learned what metastatic means yet, metastatic cancer is essentially when the cancer invades your entire body. It's not just localized to the breast tissue or the prostate tissue. The cancer can move to the lungs, to the brain, to the bones, and that's essentially what metastasis means. Okay. Here's the breakdown of breast cancer in the U.S. in terms of age. You can see that middle-aged women around the age of 55 to 64 years old are of the highest risk, and that's when they're frequently diagnosed. Doesn't mean that cases can be found at a younger age or an older age, just for your reference. In terms of a little more about epidemiology, so an interesting fact is the risk of developing breast cancer is about 1 in 8 females. And in terms of ethnicity, the more common patients are typically white patients, but African American patients have the highest mortality rate where it comes to breast cancer. So there's definitely a health disparity there. In terms of causation of breast cancer, so etiology is not 100% known, but this is what's known so far. Um, Oftentimes, breast cancer is pretty much initiated, or a tumor is created from estrogen and progesterone excess, right? So you'll have a cancer cell, and estrogen and progestin can kind of increase the proliferation of the breast cancer cells until they become cancerous. Um, so that is kind of the thought behind the etiology of breast cancer. Oftentimes, it can be tied to a genetic predisposition. So you might have heard of the BRCA1 and BRCA2 genes. About 5 to 10% of all the cancers, breast cancers out there, are thought to be related to these two genes. And you know, it, it's it's often kind of known, and part, if you've done a 23andMe test before, it can test for this. So for patients who are carriers of the BRCA1 and 2 mutation, they often have increased screening protocols for these patients. They do mammograms more often, and lab tests more often, just to ensure that these patients don't have breast cancer. And you can see that lifetime risk of breast cancer for these mutations is about 60 to 85%, so very high if you have this mutation. Another oncogene, so related to breast cancer, is a HER2 mutation, or overexpression. And we discussed on the last slide, 20 to 30% of these patients are HER2 overexpressors, and it does cause a poor prognosis for some of these patients. And we'll discuss eventually that there are a lot of treatments now that are specifically geared to patients who have HER2 positive breast cancer. So what are the risk factors of breast cancer? So there's definitely environmental exposure can be one, and then we discussed a genetic predisposition. In terms of family history, I would note that greater than about 60% of breast cancer patients have no identifiable risk factor besides being female, gender, and their age. But definitely genetic predisposition is probably the biggest thing to take away from this slide. Other than that, early onset of menstruation, so we define that of less than 12 years of age when a female first menstruates. Dead breast tissue, alcohol consumption, so alcohol can increase risk. Use of oral contraceptions, so specifically ones that contain estrogen. And the last one to keep in mind is obesity, and the thought behind that is it's secondary to an increase of circulating endogenous estrogen levels from fat tissue that can increase the risk of breast cancer. Okay, so how is breast cancer diagnosed? So oftentimes patients will feel a palpable lump, and it usually will be painless. It's rare for it to be actually painful. And they'll go to their clinician, and the clinician will perform a physical exam and look at the potential risk factors that the patient might have and kind of use clinical judgment from there. In terms of imaging, patients can do a mammogram, I'm sure you've all heard of, or you can do an ultrasound to see if the lump, how the lump looks like under an ultrasound. And if there is a high suspicion of breast cancer, a biopsy can be performed to look at the actual tissue to see if it is cancerous or not. Part of the diagnosis is looking at the receptor status. So once a patient is thought to have breast cancer, the biopsy will help determine what kind of breast cancer a patient has. And there are different receptors that can help guide us throughout the treatment of breast cancer. The 2 or 3 main ones on this slide are, first, hormone receptors, so actually having estrogen and progesterone receptors on the cells. So ER stands for estrogen, PR stands for progesterone. And then also looking at HER2 receptors, which we discussed on the previous slide, which is an oncogene. HER2 is involved in proliferation of breast cells. So a patient can be classified as ER positive, PR positive, HER2 positive, or they can be negative on those ends. So sometimes you can have a ER/PR positive patient but a HER2 negative patient, or in other cases they can be negative for all these receptors. I'm sorry, I just realized that I did not have that on the slide, but here it is. Kind of an overview of the diagnosis. Just clicking through this to put it up here. Next, we'll talk about staging. So we have the diagnosis, we have the receptor status. What determines the stage? And in breast cancer, and similarly to other types of cancer, we stage patients from stage 0, or that's pretty much not cancerous, to stage 4, which is metastatic. So early stages of breast cancer is typically curable. So stage 0 through 3, we're able to treat patients and hope to cure them of their breast cancer. However, stage 4, when a patient's metastasized, at that point, it's thought the cancer is incurable, and we resort to something called palliative care, which essentially means that we're doing everything we can just to make the patient comfortable, prolong their life. We can still use chemo or other therapies, but it won't be high doses, it won't be very toxic. We just want to prolong their life and make sure that the patient is comfortable. Yeah. Main differences between the 4 stages. So you can kind of see from the pictures there, the breast cancer kind of spreading throughout the breast, and then stage 3 is where it actually hits the lymph nodes close to the breast, and then stage 4 is metastatic, where it kind of goes throughout the whole body. You can see the liver there, the lungs, all being affected. Okay. So this is an overview of treatment principles. So these are some broad treatment principles on this slide, but I just want to emphasize that treatment selection is really based on many different factors, including tumor characteristics such as the histology, the staging, the receptors, the patient's genetics, the patient's performance status, how they're doing, are they able to tolerate the chemotherapy, what other comorbidities does the patient have, patient preference, costs. So these all play a role in determining the treatment plans, right? So, you can look at the NCCN guideline, but there are a lot of other characteristics and features that go into play when deciding what treatment to give. But back to the slide, here's an overview for the curative stages, stage 1 through 3. We can use surgery, and then along those lines, we can use combination regimens. We can combine hormonal therapies, which we'll discuss. We can add HER2 therapies if the patient's HER2 positive. And then there is something called neoadjuvant and adjuvant therapy. And essentially what that means is, let's say we want to use a surgical resection of the breast cancer from the breast, removing the tumor. We can either apply chemotherapy or some kind of therapy before the surgery, or we can give it to the patient after the surgery. So if we give, for example, chemotherapy before the surgery, that's called neoadjuvant therapy. It's considered preoperative chemotherapy or any therapy to reduce the size of the tumor for breast conservative surgery. So I want to give a patient therapy to reduce the size of the tumor, so it will make it easier for me to remove the tumor during surgery. Or I can do the surgery and then give the patient chemotherapy afterwards. And the thought behind that is to, let's say I get the tumor, and just to make sure I got every last piece, I'm going to give someone this chemotherapy or therapy afterwards to make sure I eradicate any residual disease that might still be there. And then stage 4, for the non-curative patients, that's when more of the chemotherapy starts coming into play. And then you also have the same HER2 treatments and the endocrine treatments as well, the hormonal therapies if the patient is estrogen positive or progesterone positive. So here's another slide that kind of talks about or shows visually the difference between adjuvant chemotherapy and then neoadjuvant chemotherapy, and you can see the orders there. I will just point out that typically if the tumor size is greater than 1 centimeter, patients will do adjuvant chemotherapy. That's kind of in the guideline, and just something to keep in mind. Okay. Then here is just a visual kind of overview of how hormones play a role in classifying the type. So for example, in the estrogen receptor pathway, if a patient is ER positive, estrogen enters the cell and binds to the estrogen receptors there, and that triggers cell proliferation. In this case, it would be a cancerous cell. So when you see in the right side of the screen, if we give patients estrogen, the cells will proliferate, the cancer cells will grow. But if we don't give them estrogen or we block estrogen, that can help slow the growth of breast cancer. So in terms of endocrine treatment, so with blocking estrogen and progesterone, there's a couple hormone treatment considerations. So hormone receptor status predicts if a patient will have a response, so they need to be ER or PR positive to receive these endocrine therapies. And it will be important to know if a patient is having menopause or not, or at menopause. So a patient, just for definition's sake, a patient's considered postmenopausal if they've had a bilateral oophorectomy, which pretty much means removal of one or both of your ovaries, or greater than the age of 60 years of age, or less than 60 and has not had a menstrual cycle for greater than 12 months, and you can see some characteristics there. So once we find out their menopausal state, we can kind of look at what are the sources of estrogen. So in premenopausal females, estrogen can come from the ovaries, right? So that's a very common source of estrogen. And in postmenopausal women, ovaries no longer are a source of estrogen. So it will make more sense when I talk about some of the therapies. Some therapies work directly on the ovaries, so it will be important to know if a patient's premenopausal or postmenopausal. Which actually leads me to this slide and kind of deciding which therapy to use. So once we decide that the patient is ER or PR positive, we'll figure out if they're premenopausal or postmenopausal, and then that'll guide us on which treatment to use. You can see tamoxifen can be used in either arm, either for premenopausal or postmenopausal. However, aromatase inhibitors on their own can only be used in postmenopausal women. And the thought behind that is that aromatase inhibitors have no activity on ovarian production of estrogen, so they're only effective in postmenopausal patients. Or you can use them in premenopausal women, but they have to have therapies that suppress their ovarian estrogen production, right? So key point here is aromatase inhibitors on their own can be only used in postmenopausal women, but if you want to use an aromatase inhibitor in premenopausal women, you have to pair it up with a therapy that causes ovarian suppression. For most of these endocrine therapies, they're typically used for 5 to 10 years, 10 years being the maximum amount of time that it is used. So starting off with our first drug here, tamoxifen. So tamoxifen is a selective estrogen receptor modulator, commonly known as a SERM. That's the abbreviated form of that. It competitively binds to estrogen receptors, so blocking estrogen in the tissues. Tamoxifen is usually recommended for 5 years and can go up to 10 years, but again, no more than 10 years. Some big side effects associated with it: patients experience hot flashes, night sweats, thrombotic events is a big one, so higher chance of clotting, and you can see the management of some of these side effects on the right-hand side. And lastly, drug interactions. So there is a classic hallmark drug interaction to be aware of with tamoxifen and to look out for, especially if you're an oncology pharmacist or working in the community. So tamoxifen is a prodrug, and it requires CYP2D6 to be converted to the active metabolite. So any concurrent use with a strong CYP2D6 inhibitor will decrease the ability of tamoxifen to be converted to the active metabolite. So some of the biggest things that come to mind are some of the SSRIs, so things like paroxetine and fluoxetine are strong CYP2D6 inhibitors. So some patients will be switched away from those drugs to other SSRIs if they have tamoxifen on board. Okay, next we have the aromatase inhibitors. So these work a little differently than the SERM tamoxifen that we discussed on the last slide. What these do, they stop, you can see the picture below, they stop the conversion of testosterone to estradiol, which is a form of estrogen. So I didn't know this when I was in school, but females have testosterone, and it is converted to estradiol through aromatase. So we are blocking the body's ability to convert it, right? And again, no activity on ovarian production of estrogen, right? So the body will still make estrogen, so we would have to pair this agent with a ovarian suppressing treatment. Some of the side effects here are similar. You'll also see more myalgia and arthralgia, and then osteoporosis risk is a little higher here, so you can see the management on the right-hand side. Okay. And then we'll be discussing another way, another form of endocrine treatment, LHRH. So we talked about ovarian suppression. So finally, we're here to discuss how do you suppress the ovaries from making estrogen. So these are the two drugs that can do it. So they're considered LHRH agonists. So leuprolide and goserelin. So you can combine these agents with the aromatase inhibitors, specifically for the premenopausal women. You can kind of see the adverse effects on the slide, the hot flashes and injection site pain. So these are injectable agents rather than the two oral agents that we discussed previously. Okay. So we've gone through all of the endocrine treatments, right? So we've addressed a patient that has ER or PR positive breast cancer. Let's say they progress and we decide that we need to use chemotherapy, which certainly happens to a lot of our patients. We're going to discuss chemotherapy now. So this is an example of a regimen, chemotherapy regimen, that is very common in breast cancer. So this regimen is called ACT. So there's an abbreviation there, a couple of abbreviations. So AC stands for doxorubicin plus cyclophosphamide. You might be wondering, why does doxorubicin stand for the A? It's for the brand name, actually. So the brand name of doxorubicin is adriamycin. So that's the A there, and then the C is for the cyclophosphamide. And then you add T on there, that's the Taxol. That's the name of the chemotherapy. And then there's also a G on there. It's GCSF. That is a medication that's used to increase neutrophil counts, white blood cell counts, after a patient receives chemotherapy, because chemotherapy decreases white blood cell count. So the GCSF boosts the white blood cell counts after the chemotherapy kills those cells. You will be learning more about this in your supportive care lectures. I would have preferred you have your supportive care lecture before we talk about all these cancers, but in terms of scheduling, they put your supportive care lectures afterwards. And so this is an example of the regimen. So for example, if you look at, February 14th, right? You see the patient starts the next day, February 15th. They'll receive 2 chemos on February 15th, doxorubicin and cyclophosphamide. And then 24 hours later, they'll give the patient GCSF to increase their white blood cell count. And then after the patient's done with those 4 cycles, so that you see they started AC back in January, they had 4 cycles. Patient then can move on to the Taxol, which is used after they finish the AC. So then they do Taxol once a week as a kind of like a maintenance chemotherapy for them. Okay. So this is the first chemotherapy that we're going to discuss. It's called doxorubicin. They called it doxorubicin because it's red. You can see ruby. It's a very noticeable agent. As some fun fact about it, it can, when a patient gets an IV, it can turn their urine red, and it can turn their sweat red, their tears red. So if you don't counsel a patient on this, they'll really freak out and probably go to the ER, and just everyone will have to figure out what was going on. A lot of ER docs probably won't know doxorubicin is red, so that's something the pharmacist can educate the team about. So doxorubicin is considered to be a type of anthracycline. It is part of the ACT regimen that we showed on the last slide. You can see some of the side effects there. First one is nausea, vomiting. That's very common in a lot of chemotherapies, and you'll discuss this more in your supportive care lecture about the differences between chemotherapies in terms of them being how much nausea they cause, whether they're low, medium, or high risk of causing nausea. So this one specifically is moderate to high risk of nausea. It can also cause some cardiomyopathy, and the way we evaluate to see if the patient is getting any cardiomyopathy from the agent is we look at left ventricular ejection fraction before, during, and after treatment. And there's something called a cumulative dose toxicity. So this is an agent where we essentially keep track of how much of the doxorubicin we give over time. There is a lifetime maximum. And the package insert essentially says you don't want to give a patient more than 450 to 550 milligrams per meter squared of doxorubicin throughout their life. If you give them more than that, they are at a very high risk of getting cardiomyopathy and progressing to heart failure and so on and so forth. So we try to stay below that 450 to 550 milligrams per meter squared. Now, if a patient gets close to that maximum, or we really need to give them more doxo, even though they're getting to their close to their lifetime dose, we can give them a medication called dexrazoxane, or brand name Zinacard. Essentially, what that does is it helps protect the heart from having the cardiomyopathy. Next is extravasation. So these medications, essentially, what this means is if the medication, you're putting it through your vein, if for whatever reason the needle moves and it goes into your tissue, it goes out of the vein, it can be very irritating to the skin and start destroying the skin and the surrounding soft tissue. So if that ever happens, which sometimes it does, we have to put cold compresses around that area where it happened, and then we have to give an antidote, which is also called dexrazoxane. So it's the same exact drug, different brand name, different dosing. So keep in mind that Zinacard is different than Totect. So dexrazoxane Totect is the antidote for extravasation. We discuss the discoloration and myelosuppression, so it decreases cell lines like white blood cells, red blood cells, things like that, platelets. So we use GCSF to increase the white blood cells, neutrophils in these patients. Next, we have cyclophosphamide, which is considered an alkylator. Also causes nausea, vomiting. Something unique about this drug is it causes hemorrhagic cystitis, where essentially what that means is one of the metabolites gets in the bladder and starts irritating the bladder walls, and it causes painful irritation. You can see some bleeding, and that typically occurs with higher doses of cyclophosphamide, so around 1 to 1.5 grams per meter squared. And ways to prevent that, we give a lot of hydration for these patients. And the drug in this case to help prevent that is called Mesna. Mesna is administered for high doses of cyclophosphamide, and it's used to protect against hemorrhagic cystitis. And the last thing is the alopecia. So I'm sure you know that a lot of patients lose hair while they're on chemotherapy. Biggest takeaway is you tell patients that hair will grow back eventually, right? But it could have a different color or texture, and tell them to keep in mind to use gentle shampoo and soft brushes. So you might be wondering, why does chemotherapy cause hair to fall off and things like that? So chemotherapy works on fast dividing cells, right? So hair cells, follicles, are fastly dividing. So those are hit pretty quickly and can cause hair fall to fall out. So that, and then mucus cells, which are throughout your GI tract, are fastly dividing, so those can be killed off quickly as well and cause some other side effects that we can discuss also. And the last chemotherapy in the breast cancer module is the taxanes, so specifically paclitaxel here. Paclitaxel is known to have a lot of hypersensitivity, so patients have often reactions to the medications, and we have to give pre-medication. So before they take the paclitaxel, we got to give meds to make sure that doesn't happen. So we can give them things like H1 blockers like diphenhydramine. We can give them H2 blockers like famotidine. We can give them steroids in an effort to prevent any infusion-type reaction, right? This medication is also known to have some peripheral neuropathy, so kind of like tingling, feeling, and numbness associated with it. It is reversible once treatment is stopped, and if it is very severe for some of these patients, we'll reduce the dose. And then you can counsel patients to avoid like touching hot or cold things if they can, because that can exacerbate the symptoms. Oftentimes when you're checking chemotherapy, there will be certain things called hold parameters, meaning the provider tells you to hold certain things hold the chemotherapy if their labs or something is going on that's not right. So for example, for the AC regimen, the provider said, hey, don't give the patient the chemotherapy if their ANC, which is absolute neutrophil count, which is kind of part of their white blood cells, is equal to or less than 100 cells per microliter. And they also said don't give the patients the chemotherapy if the platelets are less than 100 cells per microliter. And also they'll put hold parameters on bilirubin, AST, ALTs, and then you can see the cardiac function. So we can review the left ventricular ejection fraction. If it's too low, there can be a hold parameter for that. Or if they're getting close to their lifetime dose maximum, we can put a hold for that or kind of check that and let the physician know. So sometimes they'll order the chemo ahead of time and don't review all the labs yet that the patient has. So it's the pharmacist's job to make sure that we're providing the safest treatment to the patients, and we certainly don't want to harm them. So that's the point of hold parameters. And then there are specific hold parameters for the T, also the Taxol, that you can see below. Some supportive care medications are listed on this slide. I don't want to discuss this too much because you'll have a supportive care section, but essentially some of these are you give antiemetic medications, which are, the Amend, the Aloxi, and the steroid actually is considered an antiemetic, so the Decadron. And you can also give that GCSF, which is the pegfilgrastim, to help their white blood cells. And then you can see for under the T, those are some things to prevent hypersensitivity or infusion site reactions that we discussed previously. So I have a case for you. Take a moment, look through the slide, read through the slide, and I'm not going to read it here, but I'll ask you one question on the next slide. So you can pause it and kind of read through this. And then here's the question. Can you identify other risk factors for ML which might increase her risk for breast cancer? So you can pause again, take a minute, think about it, and I'm going to put the answer now. So you can see that, you can see that there are many risk factors that the patient has, or at least a few, that will increase her risk of breast cancer. Okay, so there's that. I'm going to go on to the next slide. And then we have the next treatments that we're going to be discussing. So we discussed chemotherapy. We discussed endocrine therapy. And now we're going to talk about some HER2-specific therapies. So I just want to go over HER2 real quick before we talk about the therapies. So the HER2 therapies are monoclonal antibodies. And the HER2 you can kind of see on the slide. They are considered an oncogene on these breast cancer cells. And essentially what our drugs do, they're monoclonal antibodies that bind to the HER2 receptor and block them. And the HER2 gene, essentially, what it does, it promotes the growth of the cancer cells, so we would be blocking the growth of these cancer cells through HER2. So under A, you can see trastuzumab, which is brand name Herceptin, binds at the HER2 receptor. You can also see pertuzumab, which is Perjeta, under C. Similarly, it's also a HER2 drug, but it binds at a different spot on HER2. You can see it's at a different location. So just a different binding site. And the last one, TDM1, brand name Kadcyla. It's an interesting one that we'll talk about later, but it's part HER2 and it's part chemotherapy, so it's like two drugs in one. So here's the Kadcyla, the last two drugs in one that I was talking about. Couple key points. So it has the monoclonal antibody that binds to HER2, but it's also bound to chemotherapy, right? So it's called a antibody drug conjugate. It has two drugs in one, so an antibody and a chemotherapy drug. And how this works is it binds to the HER2 spot receptor on the breast cancer cell, and then what happens then is the cell is internalized. The drug is internalized, and the chemotherapy kind of will kind of work inside of the cell and destroy the breast cancer. Okay. So in terms of the two monoclonal antibodies, we have trastuzumab and pertuzumab. A couple things to note on this slide is the infusion reactions. These medications also need to have pre-medications associated with them to prevent that. There is also a risk of cardiomyopathy, which is reversible. So in comparison to doxorubicin, that also causes cardiomyopathy, but that one is non-reversible. This one does cause cardiomyopathy that is reversible, right? You don't want to use it at the same time as the doxorubicin. You want to space it out because they both can cause the cardiomyopathy. You don't want it to be really additive that close together. Um, and the standard of treatment for a lot of these agents, the HER2 agents, is 1 year. And if it doesn't work within that year, then you essentially will try a different treatment. Right. Last thing to note is pertuzumab, Perjeta, is never used on its own as a single agent. It's commonly paired with trastuzumab, and it has more efficacy that way. So you don't really give pertuzumab by itself. Okay. Next are some monitoring parameters for these antibodies. So you look at cardiac function again, and you can see the hold parameters are listed on this slide as well. Some pre-medications and hypersensitivity medications can be found here as well. Nothing that stands out versus some of the other chemotherapies that we discussed or other cell therapies. All right, so we're wrapping up here. So this provides a nice overview of the breast cancer treatment guide through NCCN. Of course, the NCCN guideline is much more intricate than this, and this lecture provided you kind of an overview of some of the therapies that are used, so you can kind of read through that there. And then you can see case 1 continued. It's the same exact patient case, but I just want to go through a couple things with you, and this will wrap up the lecture. So the question is, per the NCCN guidelines, assess whether or not ML received appropriate treatment for her breast cancer based on her staging and results of her biomarkers. So you would, for this, have to go and make an NCCN account and log in and access the breast cancer lecture. And I just wanted to show you a screenshot of what the guideline looks like. So you can see this is kind of a screenshot of the breast cancer guideline for patients who are getting pre-neoadjuvant or adjuvant therapy, and for patients who are HER2 negative. And you can see the preferred regimens there. One of them is the AC followed by paclitaxel, which the patient received. So that is one of the recommendations that the NCCN has. You can also see the dosing there if you are curious. Part of the guideline as well will have that. You can see the dosing of the doxorubicin and the cyclophosphamide. So this concludes my presentation for the breast cancer module. I have my email address down there. If you have any questions, feel free to contact me. And then at this point, go ahead and skip on over to the prostate cancer lecture. It'll be a nice continuation after breast cancer. And I won't again have a synchronous session for these 2 modules, but I will encourage you to attend the office hours, and we can discuss more information and go more in depth in breast cancer and prostate cancer, especially if you're interested in the topic or have any questions you'd like answered. Thank you.